This one worries me. This one worries me a lot. I think this could end up hurting a lot of children. And I mean, obviously, you clicked on the video, so you know I'm talking about the PECARN C-spine rule. Now, like everything that comes out of the PECARN group, this is a huge, high-quality study. Everybody working in emergency medicine, pediatrics, needs to know the research. But I think it's really important to separate high-quality research from the resultant rules. Just because the rule shouldn't be used doesn't mean that your research wasn't valuable. So let's talk about the research first, and then we can get into the rule itself. But I'll put the bottom line right up front here. No one should be using this rule. If this rule is widely adopted, it will almost certainly end up dramatically increasing our use of imaging in children. But cart before the horse here. So this is a big multi-center effort from level 1 pediatric trauma centers. And that's important. We'll come back to that. This is a 2-part study. It's derivation and then validation. And they include children with blunt trauma who either arrived by EMS to the trauma center, were a trauma team activation, or who had C-spine imaging ordered and done by their treating physician. So it's a very high-risk cohort. Very high risk, really, like trauma team activations brought in by EMS to pediatric level 1 trauma centers, right? You're going to hear about this rule everywhere, but if those aren't the patients that you're seeing, if you're not working at a trauma team at a level 1 pediatric trauma center, this research just isn't for you. But that, unfortunately, is not how the knowledge translation is being framed, at least as far as I've heard. Now, despite this select population, this is a huge study. The derivation cohort had over 12,000 or almost 12,000 kids, and the validation cohort had over 10,000. Those are huge numbers, but one concern with this study is that they do miss a huge number of kids. Well, more than 30% of eligible kids just weren't included, and they don't really explain why, and that's not great. Now, from all of these kids, they come up with a 2-part rule. And there are 4 high-risk features, and they are very high risk. So this is a GCS between 3 and 8, unresponsive on that AVPU scale, the need for intervention in any of the ABCs during the trauma assessment, or a focal neurologic deficit present in the emergency department. And if you have any of those, you have at least a 10% risk of C-spine injury, very high risk in this population, and they suggest a CT scan. Can't really argue with that. I don't think I need a rule to tell me that I should be concerned about the C-spine in a comatose trauma patient or a patient with focal neurologic deficits. And we're going to come back to that. But when a rule just tells you what you already know, it's hard to see how it could possibly improve your current practice. Now, I think this part of the rule will be misinterpreted in the long run. We know that the inter-rater reliability of GCS is awful. So there will be lots of kids with a GCS 11 who will be called 8. And incorrectly get lumped in here. I think the bigger issue is probably with the ABCs. In an interview, the lead author is very clear about this. An abnormality of the ABCs is it only counted if the trauma team had to stop and intervene on the ABCs. That is a huge caveat that's not highlighted in the paper or in any of the knowledge translation tools that I've seen. Kids always have tachycardia in the ED. This population in particular, a trauma team activation, they're going to be scared, they're going to be in pain. Tachycardia will be 100%. In the study population, the tachycardia was apparently ignored unless the team needed to stop and act on it, give a transfusion or whatever. But that will definitely be misinterpreted in the real world, making the specificity of this rule way worse than what is actually reported here. So those are the high-risk features. There were 156 children with C-spine injuries that had none of those high-risk features. That represents a risk of 1.4%. And that's probably going to be the crux of this paper. If you don't have any of these high-risk features, you already have a very low risk of injury. And can this rule make it any better? And this is especially true if people try to generalize these results outside of the pediatric trauma team activation. In those settings, if you don't have any of those high-risk features, you almost certainly have way less than a 1% risk of injury. And maybe you should just stop. But that's why this rule, especially at this time, before external validations, should not be used. Now, to try to catch that last 1.4%, they add 5 more factors. self-reported neck pain, and this is another one where the manuscript is missing a key detail. The child has to volunteer that they have pain. You can't ask them about it. Again, guaranteed that people mess this up in the real world, and the rule will look worse than it does on paper here. So self-reported neck pain, any altered mental status, substantial head or torso injury, and substantial meant either a need for surgical intervention or admission, or neck tenderness on exam. And in the final rule, they suggest X-ray in this group. So how did this rule actually perform? Well, honestly, in my opinion, not great. The sensitivity is about 95%, but the 95% confidence intervals go all the way down to 90%. So this rule will miss between 5 and 10% of C-spine injuries. That's not a rule. That doesn't make me super comfortable. And then, like all rules, the real problem lies in the specificity. The specificity is not great at about 60%. So before I even get into the major limitations of the research, I want you to think, is 95% sensitivity good enough for you to adopt a rule when we're talking about C-spine injuries? It just doesn't sound that great to me. Now, the authors will emphasize the 99.9% negative predictive value, but there are a lot of problems with negative predictive values. And if you're going to be fair, and they don't do this in the paper, but if you're going to be fair, you have to at least mention the positive predictive value as well. It's only 3%. It's awful. So again, let me say, this is tremendous research. We can learn a lot about C-spine injuries in very high-risk pediatric trauma. But when I sat down to read this paper, I got very, very nervous. This rule is not ready to be used for a very large number of reasons. But if people start using it, I think it will lead to a dramatic increase in the use of imaging. And that will ultimately hurt a lot of kids. So to start, we have the general cautions with any decision rule, right? This has not been validated. And decision rules very frequently look way worse when they're retested in external populations. It hasn't been tested against any gold standard. And the gold standard here would be physician judgment. We don't have an implementation study, so we have no idea if this would decrease or actually increase imaging in real-life practice. Now, I'll have a whole video up soon, probably, on the many issues with the science base for our decision rules right now, and how many we're using without appropriate evidence to use them, and how they're causing a lot of harm. But the key point is that you need to have all the steps in the research process before you start adopting these rules. But I think there's more reason to be concerned about this PECARN rule in particular. Now, first of all, this represents an extremely high-risk population, right? Pediatric patients presenting to a level 1 pediatric trauma center. And even then, the baseline risk for a C-spine injury was only about 1%. So for the average kid presenting to a normal community emergency department, the baseline risk is going to be much lower, and the false positives will absolutely swamp the true positives. Trauma is the second most common presentation in pediatrics. And we see way more kids in the community than they see at level 1 trauma centers, but our population looks nothing like the kids in this trial. This research just does not apply to the vast majority of pediatric trauma. Now, these authors claim that the rule would decrease imaging in their centers, but that's based on a baseline where 60% of the kids were being imaged, including 17% of kids receiving a CT of the C-spine. I hope that highlights how different this population is from the population that we are seeing, where the C-spine imaging rates are like way below 1%. Right? This is not a test that gets ordered with any regularity, although that might change if people start using this rule.
Oh my, they certainly ordering a lot of CTs these days.
Now, perhaps the biggest problem with this study is that they just forgot or didn't include a control group. Without controlling this rule to the current gold standard, physician judgment, we have absolutely no idea whether this is going to make practice better or worse. But I want you to think about your practice for a second. How often do you really struggle with this decision? How often, as a community emergency doctor, are you ordering neck images in children? How many C-spine injuries have you seen missed in the pediatric population? For the most part, this is like a completely non-issue. I've ordered between 5 and 10 C-spine images in my entire career in the pediatric population. So adding a decision rule with low specificity is likely to make us much worse at our jobs. And considering that this is mostly a non-issue around the world, and that pediatric C-spine imaging is ordered very rarely on average in the average emergency department, it seems like this will almost certainly make our practice worse. I don't see how it can't. Now, without implementation studies, I can't say that definitively. We just don't know. But I want to run a little thought experiment with you. And in my mind, it makes it very clear that if this rule ends up being used, it will cause a dramatic increase in imaging. So let's imagine a world where this rule is used perfectly. Now, that world won't actually exist, right? We're going to see indication creep. We'll see this rule used widely without any regard for pretest probability. The rule will be applied incorrectly. But let's ignore all that and imagine a perfect use case. So in this scenario, the rule is only applied after the imaging has already been ordered. The patient's sitting in radiology, ready to get their test. And in this setting, the rule can't possibly increase imaging because the test is already ordered. And so it could only possibly decrease testing. So I want you to take a step back and just think, what does this rule actually say? It says that you could cancel that imaging order if the patient is not altered, required no intervention in their ABCs, has no focal neurologic deficits, has no neck pain, no substantial head or torso injury, and no tenderness on exam. But pause. Think about that patient. In your current practice, would you ever order imaging on that patient? Why in the world would you ever order imaging on a patient with no pain, no tenderness, no neurologic deficits, and no other substantial injuries? An awake patient. That makes no sense at all. No clinician I have ever worked with would ever order imaging in that patient. And we sometimes get lost in like the scientific jargon and the numbers of a paper, and we lose track of common sense. But forget about the numbers for a second. Just think about what this rule is saying. No emergency physician would ever order C-spine imaging in an awake patient with no pain, no tenderness, no neurologic deficits, and no other substantial injuries. Or if you were ordering that imaging, you probably had some other really good reason, and it's not clear that a rule with a 90 to 95% sensitivity should talk you out of ordering that test. If you would never order imaging in that patient, there is no possible way this rule could decrease imaging in your practice. I'm going to say that again. There is no way this rule could possibly reduce imaging because no sane emergency physician would ever order imaging in the low-risk patient being described. You don't need this rule because you're already excluding all of these patients using basic clinical judgment.
Let me get this straight. The patient is awake, has no neck pain and no tenderness, has no neurologic deficits and no other substantial injuries. You needed a rule to tell you not to order imaging? For shame. For shame.
However, we know that this rule will not be applied in the perfect scenario this thought experiment describes. It won't be applied only after imaging has been ordered. It will be applied in everyone. It will be applied in patients who you currently would never even consider imaging. You'll get worried about the exact definition of a substantial head injury. You'll waffle about the fact that the kid might have said his neck hurt 3 hours ago on scene despite having no complaints now. You'll wonder if the kid's natural aversion to being touched it might actually be tenderness. You'll forget the actual definition of an ABC abnormality. Or you'll worry that others will judge you in the case of a miss if there's an objective rule that they can point to that says you should have imaged. And so you will image when you wouldn't have previously imaged. And you will image a lot. That's what the specificity of 60% tells you when we aren't imaging right now. You know, in some clinical scenarios, increasing your imaging might be acceptable. Maybe we're missing a lot. Maybe we need to increase imaging to have fewer missed injuries. But pediatric C-spine injuries is just not one of those scenarios. One thing that I can tell you for certain is that there is not an epidemic of missed cervical spine injuries out there. We don't need help making this diagnosis. We aren't missing these children. So any increase in imaging will almost certainly represent pure harm. Now, we need implementation studies to be sure, but I think this thought experiment makes it incredibly clear that this decision rule will dramatically increase the use of C-spine imaging in children, and the result will be tremendous harm. It can't possibly decrease imaging because it describes a patient that no sane emergency doctor would ever have imaged in the past. We don't need a rule telling us that imaging isn't required in a patient who has no pain, no tenderness, no neurologic findings, and no other substantial injuries and is perfectly awake. But with a specificity of 60%, this rule will dramatically increase imaging. Now, I can say with absolute certainty that this rule would increase imaging in my practice. Even if I followed it perfectly, which would be hard, it will probably increase my imaging by a factor of 100 at least. It would increase imaging in every department that I've ever worked in. It would increase imaging in every country I've worked in: Canada, Australia, New Zealand. I think it would increase imaging in essentially every community emergency department in the world, because if not, we have a dramatic issue with over-testing. Now, perhaps the biggest issue we face in the modern era of decision rules is that so many of these rules are being produced in a country that is a dramatic outlier in almost all areas of clinical medicine. Okay, I think maybe I should take a brief aside. I do love poking fun at my colleagues in America. My family is from the States, and so I probably take a little too much license to joke about America sometimes. But there are definitely some problems that we need to address, right? I've spoken to a few brilliant American pediatric emergency colleagues about this paper in particular. And the conversations have gone very similar to conversations I've had in the past, over the past decade, over and over again at conferences and online with many of my American colleagues. It honestly feels like we're speaking completely different languages. One quote about this paper was, quote, "This paper makes me feel so much better that I'm justified in my decision not to order or not to image kids with no symptoms." And my head almost exploded. Like, why would you need justification not to order a test in somebody with no symptoms? And look, these are brilliant, very well-meaning people. It's the system that is shaping practice. And I haven't worked in that system, so it's hard for me to comment. I definitely don't know how to fix that system. But I think it's very important to talk about it. One, it's important that Americans know that it doesn't have to be this way. You need to pop your bubble and realize that the rest of the world is not practicing in the same way you are. The rest of the world is making decisions based on clinical judgment, and we don't need any more justification than that. But more importantly to me, and I think for the rest of the world, is we need to be very explicit about just how different practice is in America. Because there are more of these studies, the more of these studies that get published, the more we inch towards the American style of practice. Year by year, we absorb these practices without dissecting the assumptions that underlie them. And so research that might actually improve practice in certain geographies almost certainly makes it worse in others. But unfortunately, the Americans still lead the world in so many areas of medical research and education, right? And they're great, right? Canadians, and myself included, learn from incredible programs like MRAP. And the education is top-notch, but it's also very distinctly American. And not a week goes by without my jaw just hitting the floor about some statement that's just thrown out there about, oh, this is obviously the standard of care, but it's just absolutely not the way we practice anywhere else in the world. All right, that's probably enough of a ranty sidebar, but I think it's important to be clear that I'm not criticizing anybody's practice and I'm not criticizing the researchers. I'm just cautioning about generalization from research in areas with extremely outlying practice. That can be really dangerous. That could hurt us in places where our current practice doesn't match that extreme outlier. So let's get to a bottom line here. This is high quality research resulting in the derivation and initial validation of a pediatric C-spine rule. This is in a population, though, of extremely high-risk pediatric trauma patients. This rule is not ready to be used clinically. Now, if you happen to work in a pediatric trauma center and you're seeing high-risk trauma patient, part of a trauma activation, and you're considering ordering a PAN scan, and you want to use this rule to talk yourself out of ordering the C-spine portion of the imaging, I'm not going to argue with you, although an awake patient with no symptoms, no deficits, probably you didn't need this rule. And I will say this rule is still a long way from being proven to be helpful even in that situation. But if you are working in any other setting, this rule will almost certainly increase your use of imaging. This has not been studied in your population. It has not been subjected to the necessary external validation. It has not been compared to the current gold standard clinical judgment. And we have no implementation studies. This rule absolutely should not be used at this time. Look, I work in 2 busy community emergency departments with a high percentage of pediatric patients. This is just not a problem that we need a rule to help us with, at least not in community emergency medicine. This is not a condition that we are missing. This is not a condition that we are over-ordering tests. I have almost certainly imaged less than 20 pediatric C-spines in my entire career. This is a condition that is easy to assess clinically. Forget about the rule. Examine the patient exactly like you're already doing. Clinical judgment is almost certainly better than any rule that will ever be created. This video was brought to you by Dr. Pepper. Well, I guess insofar as Dr. Pepper keeps me hydrated and caffeinated. But no, obviously there are no sponsors of this channel as of yet. Huge thank you to the Patreons who have been supporting First 10 EM for a long time now and really keeping this project alive. There is now a YouTube membership that you could use to support the channel if you want. So if you like these videos and want to have them continuing to come out, check that out. There are a few perks there that you might like. Early access to videos. You can post questions and comments that might make it into our podcast. And if that's not a good fit for you, you can help a ton by just liking, subscribing, sharing these videos with your colleagues. As always, helps a lot, and I love to hear from people. So comments, I'm sure there's going to be some controversy here. Leave it all down below. Thank you so much for the support. Until next time, take care.